Hi, good afternoon. This is Fredy Dominguez with Attentive Home Care. Welcome everybody. Today we are presenting the SoCal networking virtual meeting, and our guest speaker is Dr. Thomas Lagrelius, who is a well-known doctor in all Southern California. All right, so we're going to do this. We have a few people that just joined in. What we're doing, Dr. Lagrelius wants us to introduce ourselves first before he starts speaking.
So Fredy, how many are there on right now?
Right now, there's 37 people right now.
So let's try to cut it to just a name, who you work for, and what's your question, and so we move on fast.
All right, perfect. Yes. All right. So Allison, go ahead. Name, who you work for, and question.
Hi, Allison Larrick with Cognitive Care Solutions. And my question with everybody else is, how safe is it for us to lift the quarantine and be out there in public?
All right.
Russell Martin from Silverado Memory Care. I work for our Newport Mesa and San Juan Capistrano locations. My question to the doctor is what are your thoughts on the protests going on and opening up businesses on May 1st? And what do you think about that new drug that seems to be showing, starts with an R and I can't pronounce it, but Reservative or something like that.
Right.
So those would be my questions.
All right, perfect. Thank you.
There you go. Hi, I'm Susan Embry, also with Silverado Memory Care. I serve our Tustin community and our Brea community. Oh, my question would be the same. What about opening the economy soon or back to work, lifting the restrictions? Thank you.
Thank you. All right, Mark. Go ahead, Mark.
Hello. Mark Wechter with Always Best Care. My question is, what advantage does antibody testing have, and how long do antibodies last? What kind of protection does that actually confer? Thank you.
Okay, perfect. All right, let's do Gemma. Gemma, are you there?
Yes.
Oh, yes.
Hi.
Go ahead.
Hi, everyone. My name is Gemma Benson, and I am the administrator at Vision Viejo Hospice. We provide hospice care in South Orange County. My question would be in regards to the lifting the restrictions, since I've heard, a lot of people are, they are asymptomatic. And so they don't know that they are carriers, but then they, can spread, the virus.
Okay. All right, perfect. Thank you. All right, Jim. Go ahead, Jim. Jim, better?
Okay, can you hear me?
Yes.
Can you hear me now?
Yes.
I'm really just kind of a visitor here. I'm on the insurance side of the equation, and how people get paid for the services that they provide in this pandemic.
You have a question?
No.
Okay. So my question would be, I guess, about treatment. I'm reading more and more about not using ventilators and using other therapies. So that would be the question. Thank you.
Okay, great. Thank you. All right, Cristina Quesada.
Hello, everybody. I'm Cristina Quesada with Brand New Day HMO. Well, my question would be, how accurate is all of the testing?
Dory, go ahead.
Hi, good morning, everybody. Dory Morper, Homestead Senior Care, Long Beach office. And my question for the doctor is, we've seen some reports come out this late last week, early over the weekend, about the possibility that we're way under-reporting our cases, that there's likely way more positive cases than what we first anticipated. And I wonder what your opinion is on those studies.
That is the big news. That is the big news.
Thank you.
All right, thank you. Next person, name, company, and a question for the doctor. Maribel, go ahead.
Unmute now. Hi, everyone. I'm Maribel Spell. I'm an instructor at Braille Institute. And my question to the doctor would be, do you believe there might be a second wave after we reopen the economy?
So let's do Justin. Go ahead.
Thank you. Justin Trott, Bridge Home Health and Hospice. No specific question, just wanted to get the doctor's general outlook. Thank you.
All right, perfect. Okay, we have another Justin Acuna. Go ahead.
Hey everyone, my name is Justin Acuna. My company is Second Home. We're a senior care placement agency. My question is, once everything does go, once they start lifting the restrictions, what precautions should we take to still stay safe?
Perfect, thank you. Next person, Teresa Brunella.
Teresa Brunella, Lifetime Learning Center, Long Beach City College Senior Studies. My question, doctor, is why are all the heart attacks and the deaths from other diseases down? Are they all being blamed on the coronavirus?
Okay, perfect.
Good question. Very good question. I love
perfect.
it.
Thank you.
All right, next person, Heather Reed, go ahead. I can't hear you, Heather. Okay, all right, now go ahead.
Hi, Heather from Bridge Hospice. My question is, do you feel physicians feel comfortable referring their patients to other entities during the telemedicine? Example, do you feel that you see physicians writing referrals for home health and hospice, seeing patients virtually?
Okay, great. Next person, Kathy, go ahead. Kathy Stiefel.
Hi, sorry. I was trying to unmute myself, but you already muted me. Kathy Stiefel with Oakmont of Fullerton, currently under construction.
Where are you?
She's in Hawaii.
Like I'm at the beach, putting in my hand, which I need to do. I am virtually on the beach. How about that? Drinking a Corona goes with my background, right?
All right, so your question?
I have the same questions everybody else has. Time frame on lifting restrictions is kind of top of my mind.
All right, perfect. Thank you. Melanie Bishop.
Hi, I'm Melanie. I'm with Helping Hands Senior Foundation, and I think, I'm just here to learn and answer all these questions. Thank you.
All right, thank you. Errol, go ahead, Errol.
Mute myself. Oh, you got it.
Yeah, I got it.
And I do veterans benefits. Can you buy your own ventilator? How much?
Okay. Linda Hawa, are you there, Linda?
Hi, I'm here. Linda with Alliance Elder Care Senior Placement Service. And about the second wave, she already asked the question. Thank you.
All right, thanks. All right, Jim, better? You already did it, right? So, all right, so let's see who's next. Sarah Ponce.
Hi, my name is Sara. I work with Optimal Hospice Care and we cover LA and Orange counties. And I currently don't have any questions at the moment. Thank you.
All right, thanks. Stacy, go ahead.
Hi, can you hear me?
Yes.
I'm Stacy with Valley View Gardens, and my question's like Christina's, but more specifically, I wanted to see how accurate the antibody test is, and you had the virus maybe months ago, if it still would show an antibody currently. Thank you.
All right. Next one, Gigi Manzanilla.
I'm Gigi Manzanilla. I'm with Primerica Life and Primerica Investments. So my question here is, Doctor, what is your opinion on President Trump's withdrawing support to the WHO at this time of this pandemic? Thank you.
Good question. All right, Nicole.
That's a political question. Yeah.
Hi, my name is Nicole Matavosian. I'm with Sunrise Senior in Palos Verdes. And I have a question. What are the risks or the harms in visiting with family members who have also been self-quarantined and had no symptoms?
Yeah, good question. All right, next one, Ken Carter.
How you doing? I'm Ken the Moneyman. I help people protect their serious retirement money, and it sounds like I'm in the minority here, people. I am in the camp of let's get this damn thing open, and this is just the flu, people. This is just the flu. And all your guys' questions are driving me crazy because do you ask this stuff about the flu?
All right,
That's all I
question,
wanna know.
okay, question, no opinions right now. So what's your question?
My question is, doctor, isn't this just like the flu and we're totally overreacting to this?
All right, good question. Thank you.
Good question, actually.
Yes. All right, next person's, who this? Marcela. Marcela Mueller.
Hi, everyone. I'm Marcella. I'm with Saliva Home Care, and I specifically serves LA County, though we serve LA, Orange County, and San Diego. With Salus. My question is, if a person has once tested positive for COVID-19, at which point, how many days after what treatment are they considered no longer contagious? So looking for clarity on that.
I'm Donna Rybacki. My company is American Senior Home Finders. We do assisted living placement. I want to know what the doctor thinks about the phases.
Okay.
Phases of returning to activity, the fourth phase. Okay.
Yes, okay. Sorry, who's this?
Hello. Hi, this is Debbie Hagan.
Yeah, go ahead, Debbie.
Hi, I'm a real estate agent in the Palos Verdes area. My question is, when you get the virus and you what is your chances of getting it back again? Is there a time frame of how long do we know when our chances of getting it back again?
Okay, perfect. All right, we have Robert. Are you there, Robert?
Hi, good afternoon. Robert Lynette, California Foods. Really quick on the chat, I'll put more information. My question is there different strains of this virus because there's different symptoms?
Yeah, I was muted. I'm sorry, I was muted. This is a 562 number.
Okay, go ahead.
Yeah, my name is Chris Cockey. I'm a health agent that just does Medicare in LA, Orange County. And I'm here to learn, here to listen and learn.
All right, so do you have a question or no question?
No, I just want to introduce myself and that's it.
All right, well, welcome, thank you. All right, so we have SL Hospice. Go ahead.
Yes, that's me. My name is Stephen Loy, also known as Steve the Malaysian American. I deal with placement for hospice, home health, and a senior facility in all over Southern California.
So who else am I missing before we move on? All right. Okay, then let's go ahead. So welcome everybody. I hope you're having a great day. You're staying safe out. We have Dr. Lagrelius, who I know for many, many years now. He's a well-known doctor. Well, go ahead, doctor. Introduce yourself. Tell us who you are, what you do, and hopefully you can address all of these questions. The floor is yours.
So my name's Dr. Tom Lagrelius. I run a 3-physician concierge primary care and geriatrics practice in Torrance, California. It's called South Bay. It's called Sky Park Preferred Family Care. I'm sorry, I can't remember the name of my own organization. Anyway, and I'm on the staff at Torrance Memorial, a little company, Mary Hospital, and the 3 of us are taking care of lots of COVID patients. So that was my office manager just poked in. Anyway, so these are all really very, very interesting questions. By the way, my email address is tlagreliusmd@gmail.com, tlagreliusmd@gmail.com. If other questions, you come in and I'll try to answer them. I think I and my 2 partners have probably read volumes and volumes of information on this virus, trying to come to grips with how it is different and what to do about it in the last few weeks. We have a huddle session almost every morning for about
hold on. Dr. Lagrelius, looks like something happened. Hold on. Your audio is not on. Just a second.
is my audio on now?
Okay, now I think for some reason something happened. It went off. Okay, you're good. Go ahead. Go ahead.
Is my audio on now? Well,
yes.
How much did everybody miss here?
Well, you're talking about who you are and about the company, basically. And, after the office manager walk in, so.
Okay. So anyway, if anybody wants to send additional questions, the email address is tlagreliusmd@gmail.com, tlagreliusmd@gmail.com. My two partners and I have about 1,000 patients. We're doing mostly telemedicine now in the office. I see 2 or 3 patients a day in the office. We're taking care of hospital patients. We've had about a dozen COVID patients, and we've read about everything there is to read on this subject. I think in summary, looking at all these questions, some of the most interesting ones that popped up is this the flu? I think that was one of the more interesting questions that popped up. No, this is not the flu. This is a very, very different virus. It doesn't act like the flu. It doesn't present like the flu. But it is approximately as fatal as the flu. When the initial reports about this virus came out from China, they said the death rates were around 10%, very, very high. The more people we test, the lower the death rates get. Just today was published a report out of Los Angeles County done by USC, which did a surveillance testing on several thousand people in LA to determine how many people actually were carrying this virus. And they concluded that as of about a week ago in the Los Angeles County area, there are probably somewhere between 250 and 500,000 people that have had this virus. It's very, very common, and it's very, very contagious. We talk about viruses, the contagion of viruses, based on a number we call the row number. And think about this for a minute. A virus that has a row number of 1 will not spread. It'll just sort of go from one person to the next person. Row 1 means that if you get the virus, you're going to give one other person the virus. So if the number is less than 1, the row number is less than 1, the virus will gradually diminish and go away. Flu is about 1.5. So about every victim of the flu passes the virus to 1.5 other people, and it grows slowly. Measles is about the worst virus. Its row number is 12. If you get the measles and you're in a novel environment where nobody's had the measles, 12 other people will catch it from each victim. And it grows very rapidly, exponentially rapidly in that environment. The row number of this virus was thought to be relatively low for a long time, but now people are beginning to realize it's up around 9. Every single person who gets this virus potentially can transmit it to 9 other people. So this is an explosively, rapidly growing virus in a novel potential situation, much faster than flu. So it's different from flu in that it's far more contagious, and the virus lasts longer on surfaces, and it's droplet spread, and it's much easier to catch this virus. But it's like flu in that now that we know how many people are out there and have it asymptomatically, the vast majority of people, probably millions of people, have this virus in the United States already, and they've had it asymptomatically. Now that we know how common it is and how rapidly it's spreading and how many people seem to have it asymptomatically, we're beginning to realize that the death rate from the virus is down around the level of the flu, about 0.1%. In other words, about 1 in 1,000 people who get the flu die of the flu, and probably this virus is in that vicinity someplace, a little higher, a little lower, but it's certainly not much more dangerous on a case-by-case basis than the flu. The difference is it's rapidly spreading, and that's why we're seeing this tip of the iceberg that's so deadly. Furthermore, this virus doesn't act like the flu in that it's rather slow in onset, so people can be carrying it and sick and spreading the virus for a long time before they themselves actually get sick. It's a delayed phenomenon. You get sick quickly with the flu. It's sudden onset. Your incubation period is slow. You're very sick. You isolate yourself. You get treated, and it's over. But this virus, it goes on for weeks and weeks and weeks, and patients get sicker and sicker, and they're asymptomatic for quite a while before they get sick, and they spread the virus, and that's one of the reasons the row is so high. The contagious rate of it is so high. And it doesn't kill people the way the flu kills people. The flu does cause respiratory failure, but this causes a lot of other things. It causes what's called a cytokine cascade, in which your inflammatory system goes nuts and starts doing things that are very, very bad. For example, many of the patients who die of this virus, they've done autopsies on them, their lungs are full of blood clots, little tiny blood clots. One of the patients I had in the hospital with this was a 101-year-old lady who came in with respiratory failure. She'd gone into heart failure. She had bilateral pulmonary infiltrates, and her blood clotting tests, it's called a D-dimer, were sky high in the thousands. And what's happening, and we tested her we looked at for pulmonary emboli and blood clots in her legs and couldn't find it anywhere. The usual things that cause these elevated blood clot tests were not there. What's happening in these patients, they have these little micro clots all over the lungs that are part of it's like a disseminated intravascular coagulation in the lungs, and they get clots all over the lungs. So it turns out that anticoagulants actually help these people. We're now giving IV heparin in the hospital. That's an anticoagulant for these victims so that they don't clot off their lungs. It presents very differently. It's a cytokine storm that just your inflammatory system gets you. And the people that get well from it quickly or are asymptomatic, the millions of people that are asymptomatic, they don't get that cytokine storm. They either get a very mild illness or no illness at all, and they don't even know they're carrying it. I'll tell you my own personal opinion about what we should do right now. And this is a rather recent personal opinion because we're now discovering in many places, Santa Clara County, Los Angeles County, Massachusetts, where they're doing these antibody surveillances of large numbers of people and discovering that massive numbers of people have this virus asymptomatically. I think what we should, and in view of the fact that our economy is in really bad shape right now because of what we're doing, I think what we should do is quarantine the people that are at high risk of getting seriously ill. We know the people that are at high risk of getting seriously ill have risk factors. They're the ones that are obese, massively obese. They're the ones that are bad diabetics, insulin-dependent diabetics, and out of control diabetics. People with chronic obstructive pulmonary disease that are already hypoxic to begin with. People that are in heart failure to begin with, and are very elderly. These people are at high risk. I think we ought to quarantine those people right now. Just quarantine all those people. Make sure that nobody can get at them, and send people to take care of them with masks and gloves, and quarantine them. And I think we should probably let this virus run its course in the younger population, who are very unlikely to get seriously ill and develop herd immunity. We've probably already got near herd immunity in New York City because they've had so many infections there that probably over half the population have been infected with the virus in New York by now. But in most parts of the country, there's very little herd immunity. In most parts of the country, the virus really hasn't hit. So if we quarantine the people that are likely to get sick and loosen up our restrictions so that people can get out and run their businesses and run their lives and go back to school, we will start to develop a herd immunity. And we have to grade that. We have to be very careful how fast we open it up. We may have to open it up a little and back it down a little and open it up a little. And the main problem is that they're concerned about is flooding the hospitals with too many seriously ill patients who have need ventilators and need ICUs and then run out of that capacity. In fact, that has not happened. My hospital here is half full. There are many, many beds available in the ICUs. We have far more ventilators than we really need. Even in New York City, the city of New York and the state of New York are sending ventilators to other states, which are in worse shape than they are. We have plenty of supplies. The things we're short on are personal protective equipment like gowns and masks and that type of thing. We are a little short on that, but everything else we're not very short on. So yes, I think we should gradually lift the restrictions on people's activities so that the economy can recover while we're isolating people that are at high risk of getting seriously ill if they're sick, until we get a kind of a herd immunity. This herd immunity concept is very important. If you have a virus that has a relatively low contagious rate, it's a low row of maybe 1 or 2, you only need to get maybe half the population immune to the virus and it stops growing. Because let's say the average person spreads the virus to 2 other people. And they spread the virus to 2 other people. If half the population is immune to the virus and can't get it, then they're only going to spread the virus to 1 other person. And therefore you have a line, but not an expansion. If you can get the row below 1, say to 0.9, the virus will actually disappear. But the problem with this virus is its contagious is so high, maybe 9, it means that you have to get 80% of the population immune before you get down to being only exposing 1 other person. You can also reduce that by social distancing, as we're doing, and not touching anyone, and not being around other people, and stopping all commerce and so on. You can do that. You reduce the number of people that each person will infect by doing that, but in the process, you're going to kill the economy. So going over some of these questions, people asked about tests. Well, what do we have? We have 2 different kinds of tests. One is an antigen test, and the antigen test is actually measuring the virus, actually looking for the virus itself. We do it with a nasopharyngeal swab. You stick it way, way back in the back of the pharynx, through the nose, about that far back, and take a swab back there, and send it in. There are lots of labs that'll do it. Queston and LabCorp will do it. Our turnaround times at first were a couple of days, then they got to be about 5 days. Now they're back to 2 or 3 days again. We can get these antigen tests back to see if you have the active virus at the time. The other kind of tests we have are IgM and IgG antibody tests. With any virus or any infection, 2 major antibodies come up over time. The first one is immunoglobulin M. It comes up fairly quickly within a few days or a week after the infection, and it lasts for about 40 to 60 days, and then it disappears. It's the acute immunoglobulin. It tells you you've been recently infected. It goes away after a couple of months, though, and it's gone, and so you don't see that anymore. Then there's the IgG antibody. It comes up later, several days or a week or so later than the IgM, and it continues to rise and eventually peaks out and then starts to fall, but the antibody remains with you probably for most viruses for life. And the IgG apparently is the antibody that's protecting people long-term from getting the infection again. But since this is a novel virus that we haven't even seen before, we don't know how long that immunity lasts. Nobody can answer the question, how long is your immunity going to last once you've got antibodies against this virus? Will it last 6 months? Will it last a year? Can you be reinfected? Will it last a lifetime like it does for measles and chickenpox? How long do those antibodies protect you? But they probably protect you for a long time, probably a year or more, probably long enough so that we probably could develop a vaccine in the next couple of years to start spreading that vaccine around. Question is, are we going to have waves of this over and over again? My sense is that what we're going to do is loosen up our restrictions. We're going to see increases in the number of patients. Some people are going to increase restrictions again, and we are going to see waves of that over the next few months or the next year or two. But remember, our purpose in doing all of this is not necessarily to prevent the virus from spreading. We actually want the virus to spread. We want people to become immune to it, since the vast majority are asymptomatic or minimally symptomatic, and they'll get through it without much trouble. And we need to get to herd immunity so that we can then protect the high-risk people who are quarantined at home. They can get out and they'll be less likely to get it because we have our herd immunity, and you're not going to be exposed to people that are carrying it. I look forward to the time when we can all have antibody tests and determine whether we've had the virus or not. And if we have had it, we need a sort of a mark. Maybe we put a big I on everybody's chest with a T-shirt or something. Big I, immune, and then those people are protected. We have 2 people in our practice that were hospitalized with COVID and now have positive antibody tests for IgG. I consider those people extremely safe. I suggest that they volunteer to go into the hospital and run ventilators because they can't get the virus probably, and they could be out there helping other people. And the more people we identify that are immune and have actually had the virus, we're estimating there might be 500,000 of those people in LA County that have already had the virus. Those people with positive antibodies can be a front line of volunteers to help other people at home because they're immune and they don't have the virus, and they can do services for people that need them at home. No, how safe is it to lift the quarantine? I think it's probably pretty safe to lift the quarantine for young, healthy people. We can do that right away or pretty soon. It's not safe to lift the quarantine for the people that are high risk, the ones that have the list of diseases I was mentioning. What treatments work? Well, nobody really knows. There have not been controlled blinded studies on any of the treatments that have been proposed. Somebody mentioned this drug, I think it's called Resveratrol. It's not, no one knows how well that might work. There are some promising studies that it might be valuable. But what's been touted recently in the first few weeks were a combination of hydroxychloroquine, which is an anti-malarial drug, given along with Zithromax, which is a antibiotic that works on a subcellular level and has an effect on certain viruses, along with some zinc. And most people are then putting patients, or a lot of doctors are putting patients on anticoagulants like heparin in the hospital, or oral anticoagulants like Zeroxolin, or other anticoagulants that can be given as pill form. So that's a 4-drug combination that we're using on patients as outpatients now, and it seems to work, but those are just stories. We don't know whether they really work. You know, we give this combination to patients and they say that their fevers go down and they feel better, but we don't know whether they would have gotten that improvement anyway. There are really no good studies that show that these drugs work, but we're using them nonetheless. Prevention for later. I already talked about the idea that we don't know how long the antibodies are going to last. My guess is that this is like other viruses, that the antibody protection will be very long, maybe even lifelong. I'm hoping, but we don't have any proof of that. Somebody asked about, are physicians fearful of referring to your services? I'm not. We're sending people to hospice services. I'm a little fearful of people congregating in nursing care facilities and big facilities because they're close together and they're likely to spread. We've had some really bad problems with spread through nursing care facilities. As you know, we had one in the South Bay here where we had about 10 or 12 cases and a death or two in the South Bay. The original outbreak in Kirkland, Washington, you may recall, was in a senior care facility where they lost something like 30 or 40 people out of that senior care facility. These were mostly people that had very advanced conditions and premorbid conditions, and it just wiped out the entire facility practically. Somebody asked how much a ventilator cost and could they buy one? Well, they're about $50,000, and no, you wouldn't want to buy one because you wouldn't know how to run it. And but that's what they cost. And we have plenty of ventilators. Somebody asked about, somebody asks political questions were asked about Trump. Well, you know, I don't want to get into politics too much. I think everybody should be trying to work together and do the best we can for this country. I'm inclined to agree that the country should open up sooner rather than later. I'm almost more worried about the economic consequences of this virus than I am about the virus itself. If we assume that this virus is about as dangerous as the flu, and if we assume that everybody's going to get it, then we could get as many as 3 million deaths, because the flu kills 1 out of 1,000 people, and if 330 million people got the flu, we'd have 3.5 million deaths. I'm sure we can do much better than that. The projections now are under 100,000 deaths. I think as herd immunity gradually develops, and as if some of these treatments that we're using actually work, and if we can actually isolate high-risk people and protect them from getting infected until the herd immunity develops or until a vaccine comes along, I think we have a pretty good shot at keeping death rate below 100 or 200,000, but we are going to have a lot of deaths. But think about this, 2.7 million people die every year in this country, and they die of lots of different things. And somebody asked the question, why are we having less deaths from other things? One thing that's happening right now is very clear. A lot of people who are not really dying of COVID are being labeled as dying of COVID because they came in and had a positive test. Do this little thought experiment. This is a really extreme kind of example. But imagine you came into the emergency room with a gunshot wound to the head, and somebody did a COVID test on you and it was positive. What is the probability that you'll actually have died of the COVID rather than the gunshot wound to your head? None. You died of the gunshot wound to the head, not the COVID. A lot of people are coming into the hospital who have asymptomatic coronavirus, completely asymptomatic coronavirus, and they also have a heart attack or an ordinary pneumococcal pneumonia that's really making them quite sick. The probability is very high that these people will, if they die, will be labeled as having died of COVID because they have a positive test and they came in with a diagnosis that could be related to COVID. Let's say they had pneumococcal pneumonia, which is a very dangerous infection, and they give them the COVID test and it's positive. It's likely that the death certificate will read COVID death at the very top line. One of the reasons I'm concerned about that is that hospitals do get paid more by insurance companies, and maybe the insurance guy that's on here can answer that question. I understand that the hospitals are being paid more for caring for COVID patients than they are for caring for somebody with, say, a heart attack or a stroke or a pneumonia that's not related to COVID. They're trying to reimburse facilities for the COVID illness at a higher rate so that they don't go broke, and I understand that. The other thing that worries me an awful lot is people are putting off care for serious medical problems that could end up causing them great harm if they put off the care. Patients are staying away from getting chemotherapy for their cancers for fear of being at a medical facility. People are putting off surgeries that they may really need. All elective procedures like hip replacements, knee replacements, and so on have been canceled. None of these things are being done, and the disability and pain and addiction to narcotics that will result from patients having not having these things done is real. I can tell you from personal experience. I had a right hip replacement a couple of years ago, and if I had had to go on with the pain I was having in that hip for much longer, I don't think I'd have been able to function, and I'd have probably become addicted to narcotics. It was so severe. And a lot of people are putting off these procedures right now, and we're not doing them because of this virus, and the consequences of that will be severe. Again, I'm very worried about the consequences of the economic consequences of what we're doing may turn out to be worse. I saw a political cartoon the other day that had a picture of the Grim Reaper with a sign that said COVID virus. And then next to him was an even bigger Grim Reaper with another sign that said poverty. And the caption was, you haven't seen anything yet. if this country's economy goes down, it's going to be a much worse thing to see than the. I mean, the absolute maximum we could lose from this virus would be 3 million people. That's the absolute maximum. That's a horrible, horrible, horrible number. And I'm sure it'll never get anywhere near that. I think the actual practical maximum is a couple 100,000. But we could lose a lot more than that to the Great Depression if it occurs, if we don't get this economy rolling again. All right. I think I've kind of said what I want to say. I think I'd like to ask again, what questions have I not answered?
All right, so go ahead. If you have a question, mute yourself so that way we can.
Regards to the hydrochloroquine, there's been talks about kidney and liver failure several months or possibly years after taking this drug. Are we really educating the community on how this drug, just for a quick fix for the coronavirus right now, but the long-term effects for these patients, are we really having this correct conversation?
You know, hydroxychloroquine has been around for a long time. I think it was developed in the 50s. It's an anti-malarial drug. We have probably way over 100,000 people taking it chronically for lupus. I have 2 patients in my practice that are taking it chronically. The drug's extremely safe. Long-term use has not been associated with those things, even in people who are taking it for years and years and years and years. We're talking about giving people, you know, a handful of tablets over a period of 5 days or so. This is not a serious risk. The only serious risk of these 2 drugs, is Zithromax and hydroxychloroquine, is in patients who have certain cardiac problems. It can aggravate rhythm disturbances in people with pre-existing heart problems. So you need to get a cardiogram on people or know what their EKG looks like before you prescribe these drugs. But even that is a very, very low risk issue. Now, using it as a preventative, giving 330 million people hydroxychloroquine every day to prevent them from getting the virus, I don't think that sounds like a good idea at all. You're going to have more complications and problems from the drug than you will from the virus if you do that, or you might. But it does make sense to try the drug, I think, on people who are sick. And like all viral treatments, if you talk about the flu, for example, we have drugs that'll kill flu virus. But if you don't get those drugs in the first 48 hours, they don't work. They don't work at all. You have to affect the virus while it's still replicating. We know that from the flu. So if you have influenza, which is an acute onset illness, and you get to your doctor within 48 hours and they prescribe anti-flu virus drugs, Famvir and so on, not Famvir, I'm blocking the name of the flu virus drug, but these drugs will kill the virus, and you'll do very, very well in the first, compared with somebody who the drug is delayed a week into the illness when they don't work at all. I've lost the picture here.
We can see you.
There we go. You're back. So we have to, if these drugs are going to work, they got to be started quickly. So in our own practice, what's happening is patients are calling us and saying, okay, I've got a fever, I've lost my sense of taste and smell, my fever's 103, I'm coughing. We bring them in, we get a test, we start them on this 4-drug combination, and if we're pretty sure they have it, or sometimes we wait for the test, which we're getting in a day or so, and start them, and we seem to be getting benefit. But again, it's just apocryphal stories. We don't have any proof that it's working. But I do think it's safe enough, and I do think it's the appropriate thing to do right now.
Okay, perfect. All right, we have Julie Reka. She has a question. Julie, go ahead.
Yeah.
Julie? All right, she typed that question. So how long does the virus live on surfaces? And is it necessary to clean groceries and boxes that are delivered?
No, it's not necessary to clean groceries and boxes when they're delivered. The virus will live on surfaces. We don't know for sure, but it's probably hours to days, 24 hours or so. I don't think you should wash your produce in soap and water or anything. I do think you should not use reusable bags. You should use the fresh bags from the store and then discard them after you get home. I don't think masks work very well. There's very little evidence that cloth masks do much. They only stop about 10% of the particles of stuff from getting through your mask. Mask is the most effective if it's given to somebody who's sick, just to keep them from spreading the virus. They're not very effective in terms of preventing you from getting it from somebody else. So all these mask rules are probably not necessary. The main thing to do is keep distance away from people, because when they cough or sneeze, the particles come out into the air and they go right through the paper and cloth masks. If you have an N95 mask, that'll stop 95% of the particles from getting through. But I've got one sitting right here. I hate this thing. I can barely breathe through it, but I wear it. If you have chronic obstructive pulmonary disease and you put this thing on, you'll barely be able to breathe. And you'll be short of breath just from having the mask on. So I'm not convinced that masks are of great value. I think hand washing is probably the number one thing you want to do. You want to wash your hands 28 times a day and avoid touching your face unless you wash your hands afterwards. Right here while I've been talking here, I know I've touched my face 2 or 3 times. But as long as you do that and then go wash your hands before you do anything else or touch other surfaces, you're okay. We should be very careful to avoid contacting surfaces and then putting our hands on our faces without washing them first. So hand washing, wrist washing, and forearm washing, scrubbing them all day long is the best thing you can do. Wiping down surfaces that have been, if you go to the grocery store and you're pushing a cart around, it's probably a good idea to wipe the cart down with alcohol or something before you use it. But the best thing is just distancing from other people.
Okay. Susan Embry is asking, what can we do to help with the PPE shortage?
That's kind of beyond my pay grade. LA County Medical Association is trying to get equipment out. The thing we lack in this office is gowns. We got plenty of masks. We got plenty of gloves. We got plenty of eye shields. But we don't have gowns. And I'm sending my staff out into the parking lot to do nasal pharyngeal swabs without a gown, and I don't like that.
Okay.
The gowns we're having an impossible time getting, and I don't know where the blockade is. I think most of this stuff is manufactured in China.
Yes, it is.
And China's been being uncooperative.
Okay. All right. So let me see. Elaine Carver, you have a question regarding ventilators? Are you there, Elaine?
Ventilators could be possibly causing some pretty big issues, and so I wondered about other treatments that they should before someone needs a ventilator.
Okay.
So we use ventilators when people go into respiratory failure, real respiratory failure. They can't get enough oxygen in to live. And we put an endotracheal tube in and we hook them up to a ventilator and we give them 100% oxygen and we ventilate the lung, which is so stiff and hard to move that the patient can't move the lung themselves. Ventilators are life-saving. The other thing that ventilators do for the staff at a hospital is when they have a patient with infected secretions that they're spraying out with every cough, the ventilator and the endotracheal tube can control those secretions a little bit and prevent them from being sprayed all over the place. But that's a secondary benefit, and you would never put on anybody on a ventilator or a endotracheal tube if they were already breathing all right on their own. Most of the patients that come into the ICU don't get ventilators. They just get high flow oxygen, and they do very well. I don't think ventilators cause a problem. I think ventilators are used when the patients have gone into total respiratory failure without the ventilator. And I've never seen anybody put an endotracheal tube in or use a ventilator on a patient that would have survived without it. What we're seeing, though, is these patients, once they're put on a ventilator, they're on the ventilators for a long, long time. Other kinds of respiratory failure in the past, we could usually get them off the ventilators in a short time, but many of these patients are lasting 2, 3, 4 weeks on a ventilator. And then ultimately, many of them are not surviving. Some of them do, though, and there have been, I've seen some patients, I've heard about patients at the local hospital here who've been on ventilators for a long time and gotten off them. But they don't put ventilators on patients who don't need them, believe me.
Okay. Yeah, because it's going a lot of information saying the ventilators, but as you said, ventilators are used as a last resource, so there's nothing else. All right, so Vicky, exactly.
Total lung failure.
Yeah. So Vicky's asking about if the saliva tests are effective.
I don't think so at this point. To get a good test, you need a nasopharyngeal swab in the back of the throat. I don't think saliva tests have been proven to be valid yet. In fact, and talking about the false positives, so on, antibody tests, for example, IgG and IgM antibody tests. There's a high false positive rate and a false negative rate too, where the test is given and it gives you a positive result that isn't true or a negative result that isn't true. Let's take a population of people like here in Southern California where the prevalence of the virus is relatively low. Let's say that 1 in 500 people are, well, it's maybe higher than that. They just did the LA USC study showing that there might be about 500,000 people in Los Angeles infected with the virus who have antibodies to the virus who were infected. So how many people live in Los Angeles? 20 million or
something like that?
What is
it? Sure. 20, 30 million, I'm not sure.
Let's say it's 20, and let's say that 500,000 have been infected. So there's one out of 40 people have had this virus, or 2.5%. Let's just assume that's true for LA County. It's much higher in some areas, like New York, I'm sure. Now, if you take 100 people in this community and you measure the antibodies against this virus in 100 people, and 2.5% of the population have had the infection asymptomatically and didn't know it, which is probably true, then you're gonna get 2.5 real positive tests out of that 100 people. But if the false positive test rate of the test itself is, say, 4%, and it might be that high, the majority of the people that have a positive test are not really going to have had the disease. And you're going to tell them they're safe, they're immune perhaps, and they've had antibodies against the virus when they really aren't immune. So I don't trust the antibody tests where the prevalence of the virus is relatively low. I trust the antibody tests where the prevalence of the virus is very high. Let's say you're in a population of people where half the population have had the virus, and you do the antibody test, you're going to get 50 out of 100 real positives, and only 4 out of 100 false positives, or 2 out of 100 false positives if it's a 4% false positive rate. And you can trust that test. It's pretty reliable where the prevalence is high, but it's not very reliable if the prevalence is low. If you're looking at a group of people where the likelihood of having a real positive test is 1 in 1,000, then almost all your tests that are positive are going to be wrong. And you're going to be telling people they're safe and that they're immune when they're really not. So the antibody test has to get better. Why are they false positive tests? Well, there are lots of other coronaviruses, related viruses, and the test may be measuring antibody against some of those other coronaviruses that are similar to this one and cross-react with the test. Again, we got to get better tests, and we got to get, what we really need to do is testing on large sample testing on groups like they're doing in Massachusetts and in Santa Clara County and here in LA County to find out what the prevalence of the virus is, and then we have a better idea of what to do. The antigen test for the virus itself is the test to do if you think you're sick, to decide whether you really have it or not, and that's a very good test. It's an excellent test.
Okay, all right. Bill, he works at Advanced Rehab as skilled nursing facility in Tustin. He has a question. Bill, go ahead. Bill, are you there? We cannot hear you.
Still there, Bill? Unmute.
All right, his question basically was, can washable gowns be as effective as disposable gowns for use on COVID-19 patient care?
They're not practical. I guess theoretically they could be, but they're not practical. Like when I've gone in and out of COVID patients' rooms at the hospital, it's a really quite a process putting on the suit. It's a little space suit. And then on the way out the door, it's a distinct serial process in steps to get rid of the suit. And you put it in a waste container, and I think they take it out and burn it. You have to get rid of all of the material you're wearing in the COVID room before you leave the room. And then as you leave, you strip off your gloves and scrub yourself again. I think the disposables are much better.
More effective.
The problem is we lack gowns. The hospital has plenty of gowns. I can't get them from my office, but the hospital has plenty of gowns. My office staff keeps telling me, why don't you just go to the hospital and take a big stack of gowns? I don't think I'd be well received doing that.
They're going to kick you out of the hospital.
I'd lose my privileges.
Yeah.
Pretty sure if I did that.
All right. Okay, we have a few more questions. Russell, you have a question. Go ahead. Russell Martin.
Yeah, a question about herd immunity. Yeah, can you hear me?
Yeah.
Hello?
Yes.
Yeah.
Go ahead.
I'm unmuted. Okay, cool. Okay, hear me. Okay. All right. You talk about herd immunity, but has that been scientifically proven yet? You know, because we've heard patients being reinfected in South Korea. They don't know if the virus, you know, they recovered from the virus and they got reinfected, or the virus lay dormant and came back. So what are your thoughts on that?
The reports on reinfection from Asia are debatable. First of all, was their original test correct? There's a false positive rate for tests, all tests. Was it a correct test? There are not good studies to show one way or the other on that issue, whether you can get reinfected. Eventually, I'm sure you do run out of immunity and can get reinfected. But my own personal feeling is that probably if you've had this virus, the odds are overwhelming you're not going to get reinfected in the near future. And I don't believe those reports just yet.
Okay, through that, to add to that, actually, there's someone here has a question, Tia Moore, regarding the antibodies and how effective are they? The antibody test.
The antibody test is a good test. It'll tell you whether you have IgM and IgG antibodies against the virus. There's a high false positive rate, as I say, because it probably cross-reacts with other coronaviruses, and we may be telling people they're safe when they're not. It's a good test when the prevalence in the community is very high. It's not a very good test when the prevalence is low. It's a great test when you know the patient had the virus to begin with. We've tested 2 patients who were in the hospital with coronavirus, proven with an antigen test, and their antibody tests were both positive. So it's a great test to tell people, yeah, you had it. Now you're probably immune. You're probably safe. You're unlikely to get it again. We don't know that for sure, but we're pretty sure.
Okay, Heather Reed. Heather, go ahead with your question regarding the hydroxychloroquine.
He already answered it.
I have an answer. Okay, that one. Okay. So we have one more person. All right.
Ken Carter has a question.
Oh, Ken Carter has a question. All right, Dr. Ken, go ahead, Ken.
Doctor, hi. I got a whole page full of notes here. So first of all,
you only get one question. I'm just kidding.
The only thing you said that I can't believe we said it and no one reacted to it is that we got a 0.1% kill rate. So that means 99.9% of everybody who's going to get this is going to be okay. And we have shut the world down. I mean, you got to be kidding me, Doc. That's crazy.
Yeah, but I agree with you. I agree with you, sort of. But the problem is you're left out the fact of how contagious this virus is, and how many deaths we're going to get all at once. The problem is they don't want to overwhelm the hospital system and not be able to save these sick people.
But Doc, none of that has happened. If that's really true, if it's really contagious, is what you say it is, Doc. It's row 9, almost like me. There's lines all over the place at Costco and Trader Joe's and all that, and none of those people are getting sick. So, Doc, it isn't that contagious. So let's get real here. The disease is a blood disease that affects the lungs more like a malaria. That's why the hydroxychloroquine is working. It takes the iron out of the hemoglobin to carry oxygen into our lungs. Their lungs are going up and down, Doc. They're not a ventilator.
You know, excuse me.
Okay.
I think I think you're following a particular kind of argument that's being promoted by a lot of people all over. It's a bit fringy. Okay, it's certainly not. It's certainly not the mainstream opinion.
All right.
Okay.
Thank you, Ken. All right. Anybody else has any other questions? No more questions? Okay. Anything else we'd like to add, Doctor?
Well, thanks. It's been fun. If anybody really, and by the way, if you want to pursue that argument earlier, the guy who had the strong statement a minute ago, if you want to pursue it further, you can certainly do that by email. dlagreliusmd@gmail.com. I'll be happy to try to clarify. Some of what you say is quite reasonable, and I've been saying all along that the case fatality rate of this virus is much lower than it was suspected to be, and it's turning out to be true. I'm very delighted that that's true. I tell my family that I'm doing my very best to catch it, so that I can put the eye on my forehead, that I'm immune. And they say, yeah, but it might kill you, Dad. You know, life is risk. And the thing that worries me the most right now is not the virus, but the economy. Poverty is going to be a disaster if that happens worldwide. And I think we do need to open up as fast as we possibly can. So in support of your position there, a lot of which I agree with, but not all of it.
Okay. All right. Well, thank you very much for joining us. And then if you guys have any questions, you got the email, so feel free to send him an email. And then also I can forward the questions to him too, if you want. Anybody else, any other suggestions, questions? All right. Well, thank you very much, everybody. Oh, you know what? Hold on. Somebody's texting me. All right. Looks like no more. All right. Anybody have a wonderful day. And then see you Thursday. I'll have another one for Thursday. So have a wonderful day.
Freddie, thanks.
Thank you.